Hi, I'm Chris Martin. I'm an emergency medicine third-year resident here at UF Health Jacksonville, and this is Stroke Review for the pre-hospital provider. So, goals and objectives of this talk. We're going to review clinically relevant neuroanatomy involved in stroke syndromes. We're going to discuss pre-hospital and hospital evaluation of patients suspected of stroke in order to enhance perspective for pre-hospital providers, go over some clinical pearls to hopefully optimize patient care, and then finally we'll provide some case-based clinical scenarios for knowledge assessment and a tutorial to hopefully improve pre-hospital provider awareness of stroke and stroke mimics. And all of this is not necessarily to change management, but just to provide a better understanding. Okay, a little bit about stroke pathology and epidemiology now. So stroke essentially is an infarct of the brain, similarly to when you have a heart attack, where a clotted blood vessel cuts off blood supply to the muscle of the heart, causing damage. The same idea applies here, where a clotted blood vessel cuts off blood supply, causing death of the tissue that vessel supplies. And that's what causes your symptoms. Keep in mind this is distinct from intracranial hemorrhage. Sometimes you'll hear the term hemorrhagic stroke used. For the purpose of this talk, stroke refers to ischemic stroke or infarct of the brain only, not hemorrhagic stroke or intracranial hemorrhage or or intracranial bleed. That is a distinct pathology. So nationally each year, almost 800,000 people have a stroke nationally here, and it's the fifth leading cause of death. Locally, back in 2016, greater than 350 patients suspected of stroke presented to UF Health Jacksonville, and approximately 60% of those were pre-hospital stroke alerts by EMS, and 40% were stroke alerted in the ED. So more than half of the stroke alerts were picked up on in the field pre-hospital and helped expedite patient care. So we'll jump right into it here. This is basic neuroanatomy. This is your brain, central nervous system, your frontal lobe, motor cortex, sensory cortex, parietal lobe, occipital lobe, temporal lobe, cerebellum, cranial nerves are in the brain stem. Go over some functions here. Frontal lobe involved in executive functions, thinking, planning, organizing, problem solving, emotions and behavioral control, personality. Motor cortex is going to be movement, sensory cortex, sensations, parietal lobe, perception, making sense of the world, arithmetic, spelling, occipital lobe, responsible for vision, temporal lobe, memory, understanding language. Your cerebellum is involved with movement, balance, speech, to simplify it. And cranial nerves are involved in function of motor and sensory of the face. Mainly, they have other functions too, but the purposes of this talk, we'll stick to the basics. And when we assess somebody for a stroke, any of these areas can be affected, but by history, physical examination, we can make some determinations by what's affected on physical exam. For example, the motor cortex, sensory cortex will be able to give us physical exam findings that will be able to hopefully try and localize where the infarct might be. In addition, the cranial nerves will play a role. The cerebellum will also play a role. So this illustrates a coronal section of the brain, basically going from medial to lateral, and takes a slice through the motor strip that we saw in the previous slide to indicate which areas of the brain are responsible for which areas of motor function or movement, depending on which part of the motor strip you're in. And so you can see it goes from medial to lateral, from toes all the way around to the upper extremity, the face, even the tongue, swallowing, mastication, which is chewing, so on and so forth. And basically, you'll see the two boxes there, ACA and MCA. Those are the two main arteries that make up the anterior circulation, the anterior cerebral artery and the middle cerebral artery. And So oftentimes what you'll notice is a patient that presents with a stroke involving the anterior cerebral artery, you'll notice more lower extremity weakness, whereas a patient presenting with a middle cerebral artery will present with more upper extremity weakness and can also have issues extending up in the face, like facial droop being an example. So another important point here is that extremity weakness is usually evident in the opposite side than the side of the brain that is affected, and that's basically because the nerves that control the extremity as they go down into the spinal cord from the brain actually cross sides in the brainstem. So one side of the brain actually controls the opposite side of the body from that standpoint. So this illustrates the vascular distribution in sort of a different view. So you can see the anterior cerebral artery in the red there, the middle cerebral artery in the pink, and then the posterior cerebral artery, which we'll talk more about in a second, in the orange. And those are the areas of the brain that are supplied by the respective arteries. So this slide is going into a little bit more detail and actually illustrating the cranial nerves 1 through 12, and showing the distribution of those as they go up the brainstem. And as you can see, cranial nerves 1 and 2 are more anterior circulation with the anterior and middle cerebral artery, and the rest of the cranial nerves fall under the posterior circulation in the brainstem there, actually. And so here, you kind of just see it in a different view. Essentially, cranial nerves 3 through 4 fall in the midbrain. Cranial nerves 5 through 8 fall in the pons. Cranial nerves 9 through 12 fall in the medulla. Those are all part of your brainstem. And the reason I'm bringing this up is because that can play a role with some of your facial findings in stroke. So what about the cranial nerves? I included the past few slides more or less for completeness, so take as much or as little as away from it as you would like. But basically, the cranial nerves, as I previously stated, more or less are involved in facial functions, sensation and movement of the face, with other functions as well. So let's just run through them. Cranial nerve 1 is smell. Cranial nerve 2 is your optic nerve, that's sight. Cranial nerves 3, 4, and 6 are eye movement, essentially. Cranial nerve 5 is involved with chewing and facial sensation. Cranial nerve 7 is your facial nerve, and that's involved with facial movement and has some sensory functions as well. But that can play an importance with stroke pathology. Cranial nerve 8 is related to hearing and balance. 9, essentially taste. Vagus nerve, cranial nerve 10, that's responsible for coughing, talking, swallowing. Very important. When a patient doesn't have a gag reflex, for example, likely the cranial nerve is implicated. Accessory nerve is cranial nerve 11, basically head turning, shoulder shrugging, and then hypoglossal finally is cranial nerve 12, which is involved with tongue movement. So now we'll go ahead and try and tie things together a little bit here. Your anterior middle cerebral arteries arise from your carotid artery, and that's your anterior circulation. Your middle cerebral artery, if someone had a stroke or an infarct in that vascular distribution, you would expect weakness of the opposite side and loss of sensation. As previously discussed, it involves the motor strip and also the sensory strip that's there. And you also expect aphasia or difficulty speaking, and that's for a reason we'll go into in just a second here. And then your anterior cerebral artery, which is also part of your anterior circulation arising from the carotid artery, if you had a stroke or infarct in that distribution, you would expect a weakness of the opposite side and loss of sensation. The difference being in the MCA distribution, it's more upper limb and face, and in the ACA distribution, it's more lower limb. And then, as you can see, there's also the lateral striate artery, which is involved in something called the internal capsule, which is also part of the anterior circulation, and that can cause weakness of the opposite side with intact sensation, and mainly that's going to be your infarct or stroke due to unmanaged hypertension. So what about the posterior circulation? That's something we haven't really talked about much just yet. So that's going to be your posterior cerebral artery, which actually comes off of your vertebral artery. That's going to be distinct from the carotid artery. So they have two separate origins, essentially. Your ACA and MCA come off of the carotid. The PCA comes off of the vertebral artery. And this is going to be more implicated with cerebellar signs and cranial nerve involvement, and that can play a role in helping determine if dizziness or vertigo is signifying a posterior circulation stroke, for example, and we'll go into why that is. So one of the arteries that branches off of the posterior circulation, posterior inferior cerebellar artery, can cause dizziness, vomiting, nystagmus, which is abnormal eye movement, dysphagia, which is difficulty swallowing, hoarseness, decreased gag reflex, and that's because of involvement of the cerebellum and some involvement with the vagus nerve, which we previously talked about, being implicated with gag reflex, for example. Also has something called Horner syndrome, which is essentially an eyelid droop with a small pupil and lack of sweat on one side of the face. You can have unsteady gait. You can have discoordination of finger to nose, and you can have decreased pain and temperature sensation at limbs as well. Another name for this is lateral medullary syndrome. So a lot of information on this slide, but the basic is if they're having trouble staying on their feet, they're dizzy, they're falling over, and they have some of these other signs, we suspect a posterior circulation stroke. So another branch of the posterior circulation is the anterior inferior cerebellar artery. Again, there's a lot of information on this slide, but you can get vertigo, vomiting, abnormal eye movements. You can also get ataxia and dysmetria, which are difficulty with balance and coordination, as previously stated. So overall, the idea is the same. So as promised, more about aphasia. Aphasia is difficulty speaking. It's associated with left middle cerebral artery distribution. The area shaded in gray here is the aphasic zone, known as Broca's area, and it's on the left side of the brain. And if the area left MCA is infarcting or having a stroke, this area can be affected. There's different types: Broca's, Wernicke's, global, and conduction aphasia. We won't go into the specifics for the purposes of this talk, but know that they are there. And aphasia really is more of a difficulty communicating, but with clear speech. So they know what they want to say, they just have a hard time articulating it. And that's distinct from dysarthria, which is slurred speech, which is more associated with cerebellar problems or cranial nerve dysfunction. And dysarthria is more of a posterior circulation problem. So let's go into a case. You arrive on scene to find a 59-year-old male with a history of hypertension, presenting with right facial droop and right upper extremity weakness and speech difficulty. Coworkers called 911 after noticing he wasn't acting right when arriving at work. He was last seen normal at 4 a.m. after waking up, and this was 4.5 hours ago, per the wife, who is also present on scene. Wife states he was in his normal state of health prior, denies any other complaints. He doesn't have any chest pain, abdominal pain, shortness of breath, fevers, chills. There's no history of trauma, and the history is provided by the wife and co-workers and limited by his condition. So your field assessment: vital signs, 98.7 orally is his temp, heart rate's of 102, blood pressure 142/88, respiratory rate 14, O2 96% on room air. You get a quick ACU check because you know to do that, and it's 119, normal. Exam: He's alert, no distress, but ANO times 1 to self only. He speaks in one-word sentences. He's got clear speech, but a confused response, having a hard time articulating what he wants to say. He has right facial droop, right upper extremity weakness, left upper extremity and both lower extremities have full strength. No eye or tongue deviation. So, you page a stroke alert from the field. So why did this patient get stroke alerted? This slide and the next few slides is actually from the JFRD SOG regarding acute stroke. And so, for example, this patient, you probably assessed him using the Cincinnati Stroke Scale, found that he had facial droop, some arm weakness, speech was abnormal, and time, so he meets those criteria. And then so you went ahead and performed a Lamb's stroke scale on him. You assessed for facial droop, arm drift, grip strength, and found out that he had a Lamb score of greater than 4. Now come to find out, Lamb score greater than 4 correlates with an NIH Stroke Scale and is highly predictive of large artery anterior circulation stroke, ACA and MCA arterial distributions as previously discussed. The NIH Stroke Scale we'll get into in just a few slides. So here's the SOG protocol continued. Starts on the treatment section of what to do while you're transporting these patients. On this slide towards the bottom, initiate cardiac monitoring, get a 12-lead EKG. Always a smart idea, and we'll go into some reasons why that might be later on. And then also blood glucose level, and do that before issuing a stroke alert, because we know that hypoglycemia can be implicated in causing stroke-like symptoms. And we'll also talk about that a little bit more later on as well. So if they're hypoglycemic, you can give them dextrose, and if you don't have IV access, you can try glucagon. All right, so the next few slides are basically to give an idea of what happens once you get the patient to the ED evaluation and beyond, to give a better understanding of what happens after the transition of care from pre-hospital to hospital. So what we have here is NIH Stroke Scale. Here we have the 11-point version. Essentially, it's an expanded Lamb score that assesses the severity of stroke. So we're going to go ahead and calculate that in a second. And then we also assess vitals. Patient might be hypertensive. He might have a mild fever with stroke syndrome. But we're going to go ahead and get some lab work. We're going to get an EKG, repeat an AccuCheck, get a chest x-ray and a head CT as well in the emergency department. And we'll talk about why that's important a little bit later on, why such a broad workup is important. And so this gentleman, we're going to go ahead and calculate his NIH Stroke Scale, and we're going to assess level of consciousness, assess and give him points for that. Orientation, how he follows commands, does he have any preference with gaze, is he looking one way versus the other, any eye deviation. Also assess, his visual fields, how is he seeing, does he have any facial weakness, does he have any arm or leg weakness, does he have any problems with coordination in his arms or legs, does he have any sensory deficits, does he have any aphasia, as we previously talked about, does he have any dysarthria, as we previously talked about, and does he have any problems seeing or interacting with any part of his environment. And so for him, we get a score of 11. And so that helps us move on to our next step. And so this slide also has a lot of information on it. It's essentially a simplified flow sheet of what happens with the stroke alerted patient that comes to the emergency department for evaluation. And it's a cooperative effort with emergency department, neurology, sometimes interventional radiology. And more or less, if a patient presents within 6.5 hours or so of onset of their symptoms, a stroke alert gets paged. If they have an NIH Stroke Scale of 4 or more, we'll get a CT, CAT scan of the head, and then we're going to be considering TPA. Not to say that if their NIH scale was lower, we wouldn't consider a CT head. And with an NIH stroke scale of 6 or more, we're going to consider a CT angiogram of the head and neck, which will help us better visualize those vessels because they will be a consideration for interventional radiology at that point. So just a little bit about TPA in brief. What we will most oftentimes use is alteplase, which is a tissue plasminogen activator, basically a clot buster, also known as thrombolysis, actively dissolves the clot associated with a risk of bleeding. There are indications or inclusion criteria to use it. There are contraindications, exclusion criteria to not give it, and then it can change outcomes in functionality and independence, but also comes with risks of bleeding. And so a lot of information on this slide just put there for completeness, but that's the basic point. So if the patient is a candidate for interventional radiology, what can they do? So interventional radiology can do a couple of things. They can do catheter-directed thrombolysis with intra-arterial TPA directly to the clot, which basically consists of inserting a catheter into the artery with close proximity to the clot and injecting TPA directly to it. They can go in and take the clot out, clot extraction, and generally is associated with less bleeding risk and also a more liberal time window than IV TPA. Can do interventional radiology procedures outwards of of that 4.5 hour window for IV TPA, for example. And the problem is it's limited oftentimes to large vessel occlusions and a small infarct size. So one thing that the interventional radiologist will do will calculate their aspect score. They'll look at the size of the infarct on MRI and kind of come to a determination whether or not that if they're a candidate for interventional radiology procedure. And then from a neurology standpoint, we are in contact with, administering TPA or sending the patient to interventional radiology. We're coordinating with neurology on these decisions. But some things that the neurologist also consider are, calculating a Thrive score, for example, which is associated, basically predictive of outcomes, neurologic outcomes after stroke. And also the modified Rankin scale for neurologic disability, which is something that the neurologist will calculate and assess with respect to predicting patient outcome. Okay, so what about TIA, or transient ischemic event? So this is the patient that has stroke-like symptoms of varying degrees that have almost resolved completely or completely resolved, within a certain time frame. So for these patients, there is actually an ABCD2 score. We use it in the emergency department. Neurology also uses it, and that basically risk stratifies them for the risk of stroke, having an actual stroke after having a TIA. And oftentimes these patients will be admitted and proceed with a stroke workup as an inpatient. So back to our patient. We got a CT scan of the patient's head, and the image is here on the right side of the screen. You can see on the right side of the brain, as it's sitting here, highlighted in red, an area of hypodensity, or a dark area, which signifies infarct or ischemia. And just of note, by convention, the way the CT scans are sliced and the way it's oriented, the right side of the screen actually is the left side of the brain. So the area that we're looking at as highlighted here is actually the patient's left side of the brain. So the area of infarct is on the left. So it's an acute stroke of the left MCA distribution. Of note, if there were bleeding or hemorrhage in the brain, it would show up as bright white, similarly to the bone or the skull that you can see right there surrounding the brain. So we would see something along those lines, but inside the brain parenchyma itself. So now we can compare our patient's head CT to what we've already learned and the figures we've already covered. So again, just as a reminder, even though the area of hypodensity seems to be on the right side of the patient's brain here, because of the way the CT scan is sliced and the orientation, what appears to be right is actually left brain, to just make that clear. So we have a left MCA distribution stroke, and just to compare that with the motor homunculus we previously discussed, you see in the box that is labeled MCA, that fits with the description of the patient's symptoms that he presented with the area of weakness that he had in the upper extremity, as well as correlates with his language difficulty that he had, and that correlates with the aphasic zone or Broca's area that you can see in the figure in the center of the screen there. Now let's contrast our patient's CT findings with CT findings of intracranial hemorrhage, because we did talk about it a few slides back. So as previously stated, blood or hemorrhage is going to be white on CT, whereas infarct is going to be dark. So we'll go over a few types of common intracranial hemorrhages. Subarachnoid hemorrhage, these patients will present with a sudden, maximal, different from usual headache, your thunderclap headache, usually described, and may have stroke-like signs or symptoms. They may have a stiff neck, and if it's non-traumatic, usually it's the anterior communicating artery aneurysm rupture, but it can also be traumatic as well. And you see that in the top figure here. It's basically central diffuse areas of white that you see there. You can also have subdural hemorrhages, which are the bridging veins in the brain. Typically these patients are going to be elderly patients, and they're going to have a fall of some kind, and you can see that on the bottom left there. Epidural hematomas are going to be due to temporal bone trauma. It involves the middle meningeal artery, and these patients usually have a lucid interval where they have some kind of head injury, where they don't lose consciousness, they seem to be fine, and then all of a sudden they become rapidly altered and decline quite quickly. And then lastly, you have intraparenchymal hemorrhage, which we don't have a picture here for, but basically it involves the cortex, the parenchyma, and can be quite diffuse and is also implicated in trauma. So let's continue with our case. The patient is outside of the TPA window. As we said, he's greater than 4.5 hours since the onset of his symptoms. Interventional radiology is considering taking him for, say, catheter-directed thrombolysis, but they want to get an MRI first to see how large or small the area of infarct is. Throughout his ED course, however, the patient becomes less responsive, more confused, agitated. He spikes elevated core temperature of 102. So an interval decline in mental status means more likely he has some evolving process, such as an expansion of the penumbra, which is essentially the area of brain affected by the infarct. It's expanding. It could be infection or it could be a hemorrhage. But as a reminder, patient CT was negative for hemorrhage, so less likely that one. In short, the patient was intubated for airway protection and anticipated course. So one thing that I didn't mention on the last slide was that the patient also had lab work that was concerning for infection as well. So the fever, the concerning lab work, and the declining mental status was leading us more towards infection at this point. So he ended up getting antibiotics to treat meningitis and had a lumbar puncture that tested the cerebrospinal fluid that did in fact reveal bacteria, thus confirming the diagnosis of meningitis. Also, he did have his MRI, which also showed meningitis and thought to be associated with a middle ear infection. So the patient had antibiotic coverage for meningitis. He did get some surgery done to help with the inner ear infection, and he was eventually extubated and discharged, and actually did quite well. Ended up having no residual deficits from his initial insult. So the reason I went through the last case was to illustrate the point that many pathologies may mimic stroke, whether the patient's symptoms are classic of a stroke or doesn't quite seem like a classic presentation. Stroke does have many mimics: metabolic, infectious, like the meningitis case that we just previously discussed, autoimmune, vascular, oncologic, or cancer, and psychiatric. And it's our job in the emergency department, as we're working up the diagnosis of stroke, to also rule out these mimics. And listed on this slide are just some, not all, of the potential stroke mimics that we can experience. So what I'd like to do on the next few slides to just kind of increase awareness of some of the stroke mimics and how they can present, I'd like to do a question-based tutorial to help with that. So question 1. A 65-year-old female with a history of diabetes, hypertension presents with confusion and right-sided arm and leg weakness and facial droop. Family states she lives alone and was last seen normal last night. They noticed the patient's symptoms this morning when they picked the patient up to go to breakfast. Her vital signs: 98.6 orally, heart rate 98, blood pressure 120/80, respiratory rate 18, setting 100% oxygen on room air. On exam, you notice the patient is ANO times 1, to name only, drowsy but arousable to voice, give her a GCS of 12. She has complete right upper extremity weakness. You note slurred speech, left-sided facial droop. She doesn't have any eye or tongue deviation. An exam is otherwise normal. She has no other complaints. You notice that a point of care glucose is 20. So what's your next action? Do we give glucose and reassess, page a stroke alert, intubate, get an EKG, or give a 1 liter normal saline bolus? So here we're going to give dextrose and reassess. So this is a relatively easy one. As we know, hypoglycemia can cause altered mental status and or focal neurologic deficits. The next step here would be try IV or PO dextrose if the patient can tolerate PO, and reassess them. IM glucagon is an option if you don't have any IV access. On that note, other electrolyte abnormalities such as hypokalemia or low potassium can present as paralysis that corrects when the potassium level is corrected. If the patient has a high fever, consider meningitis, like in our previous case. And when in doubt, page it out. If the patient still meets field criteria, page out a stroke alert, get them to the ED for evaluation. Next question. A 70-year-old male with a history of diabetes, hypertension, presents with confusion and slurred speech. His vital signs are temperature 98.6 orally, his heart rate is 122, so a little tachycardic, blood pressure is 120/80, respirations are 18, oxygen saturations are 100% on room air. On exam, you notice that the patient is ANO times 1. To name only, he's drowsy but arousable to voice. Give him a GCS of 12. You note slurred speech, no tongue or eye deviation, no facial droop, no weakness. Exam is otherwise unremarkable. Patient has no other complaints. Point of care glucose is critically high. What is most likely to benefit the patient? Giving dextrose and reassessing, paging a stroke alert, intubating the patient, getting an EKG, or giving 1 liter normal saline bolus? So the answer here is give them a bolus of fluid. And the reason for that is the patient likely has either DKA or HHS. These are both syndromes that present with critically high blood glucose. And these patients can be very sick, and they can have confusion or even neurological symptoms that can mimic stroke, particularly more so in HHS or hyperosmolar syndrome. And the reason is these patients can have a blood acidosis, and they can also be very, very dehydrated, usually a fluid deficit of 5 to 10 liters down. And so early fluid resuscitation would be most likely to benefit this patient. Again, if the patient meets stroke alert criteria, page it out and get them to the ED for evaluation. Next question. A 41-year-old male with a history of hypertension, cocaine abuse, complains of sudden onset left-sided arm and leg weakness associated with tearing chest pain radiating to the back starting 10 minutes ago. Vital signs: temperature 98.6 orally, heart rate 98, blood pressure 100/60 in both upper extremities, respirations 18, and he's setting 100% on room air. On exam, he's ANO times 3, give him a GCS of 15. He has left upper and left lower extremity weakness, no facial droop, no eye or tongue deviation, no slurred speech. You note weak but equal radial pulses, but he has strong and equal dorsalis pedis pulses, or pulses in the feet. You check lower extremity blood pressures, and that reveals 150/100 bilaterally in the lower extremities. So he's essentially has a higher blood pressures in the lower extremities than upper extremities. Exam is otherwise unremarkable. Point of care glucose is 120. EKG shows ST elevations in leads 2-3 AVF. What pathology is most likely? Is he having a stroke? Is he having an intracranial hemorrhage? Is he having a myocardial infarction? Is he having an aortic dissection? Or is it hypoglycemia? So in this case, his blood sugar is normal. He is having ST changes concerning for ischemia, myocardial ischemia. He is also having stroke-like symptoms as well. But the correct answer is going to be aortic dissection. So let's have a discussion about this question. So essentially, aortic dissection is a tear in the wall of the aorta that can mimic stroke symptoms due to disruption of blood flow to the peripheral vasculature. Consider this when stroke-like symptoms are related to chest or back pain, differences in pulse or blood pressure. You can have ischemic EKG changes if the coronary arteries are involved. However, the presentation of aortic dissection is highly variable, not always classic like this, and that kind of just depends on the extension of the dissection, and actually may present with no or little chest pain and may present with no neurological symptoms at all. But in this case, it looked like you were going to page a STEMI alert and a stroke alert at the same time, so it was safe to consider aortic dissection. However, when in doubt, page it out. If the patient meets field criteria for stroke, get them to the ED for evaluation, and let us figure it out. Next question. A 35-year-old female with a history of seizures complains of sudden onset left-sided arm and leg weakness after she had a seizure. A friend who witnessed the seizure states it was like her usual seizure activity with generalized shaking and urinary incontinence, lasting for about 2 minutes, then resolving. She had 10 minutes of confusion afterwards, but is now back to baseline from a mental status standpoint. Patient has no other complaints. Vital signs are essentially unremarkable. On exam, you notice that she's ANO times 3 with a GCS of 15. She has complete left upper and lower extremity weakness. Exam is otherwise unremarkable. Point of care glucose is 120, normal. What pathology is most likely here? So is it Todd's paralysis, intracranial hemorrhage, aortic dissection, stroke, or hypoglycemia? So this may be a new term, which is why I'm including it in this talk, and I'd like to talk about it. It's Todd's paralysis. And Todd's paralysis is a temporary self-limiting loss of motor function after a seizure. Consider this if stroke-like symptoms were preceded by a seizure. But also keep in mind that strokes can lead to seizure activity also, and that's going to be more likely when the seizure followed the onset of stroke-like symptoms. If the patient meets field criteria, page it out and get them to the ED and let us figure it out. Next question. A 55-year-old female with a history of a brain aneurysm presents with confusion, right-sided arm and leg weakness, and facial droop. She states she had the worst headache of her life. Vital signs: temperature 98.6 orally, heart rate 68, blood pressure 220/130, so hypertensive, respirations 12, and satting 95% on room air. On exam, you notice she's ANO times 1 to name only. She's drowsy but arousable to voice. You give her a GCS of 12 with complete right lower extremity weakness. You note slurred speech, no facial droop, no eye or tongue deviation. Exam is otherwise unremarkable. Patient has no other complaints. Point of care glucose is 120. On the way to the ED, after you page a stroke alert and let them know you're on the way, she ends up deteriorating. You note that she has a GCS of 4, she has decerebrate posturing, and a fixed dilated left pupil with mid-range and reactive right pupil. Repeat vital signs are 98.6 orally, heart rate of 42, so she's now bradycardic. Blood pressure is still hypertensive. Respiration rate is 6, and she's satting low on room air. And her EKG is actually shown below. What pathology is most likely? Does she have Todd's paralysis? She did not have a history of seizures here. Intracranial hemorrhage? Maybe. Aortic dissection? No chest pain. But her EKG does look a little ischemic, possibly. Stroke? That's always on the differential. Hypoglycemia? Her sugar was normal. So here, in this case, she's got an intracranial hemorrhage. So this patient started out with complaints of the worst headache of her life, which is a concern for subarachnoid hemorrhage. She then proceeded to have stroke-like symptoms and then a rapid decline of neurologic status. That's suggestive of an evolving process, either a massive stroke or a hemorrhage, and so more likely subarachnoid hemorrhage with rapid deterioration. The hypertension, bradycardia, and exam findings of the pupillary changes are indicative of elevated intracranial pressure and brain herniation secondary to the underlying process. And don't forget that signs of elevated intracranial pressure can be evident on EKG and can even look similar to ischemic changes. If they meet stroke alert criteria in the field, get them to the ED, let us figure it out. All right, next question. A 75-year-old male with unknown medical history presents with upper extremity weakness after a motor vehicle collision. Vital signs: temperature 98.6 orally, heart rate 98, blood pressure 120/80, respirations 18, 100% on room air. On exam, he is ANO times 3, GCS 15. You note reduced but equal strength in both upper extremities. No weakness in the lower extremities. Doesn't have any facial droop, eye or tongue deviation. Exam is otherwise unremarkable. Patient has no other complaints, and his AccuCheck or point of care glucose is 120. What pathology is most likely here? Todd's paralysis, intracranial hemorrhage, aortic dissection, stroke, or spinal cord injury. So, with a history of trauma, we suspect more likely intracranial hemorrhage. Could be a traumatic aortic dissection, or more likely a spinal cord injury. And in this case, it is a spinal cord injury. So this slide illustrates typical spinal cord syndromes. The patient in the previous question was suffering from central cord syndrome, which results from a hyperextension injury. Basically, the head and neck is extended backwards rapidly, and that leads to a bilateral upper extremity weakness. So both upper extremities, both arms are weak compared to the lower extremities. There's also anterior cord syndrome, which results from a flexion injury, basically the head and neck is flexed forward rapidly, and that compresses the anterior spinal cord, which leads to a complete motor paralysis or complete motor weakness on both sides at all levels below the level of the injury. Then you have Brown-Séquard syndrome, which is essentially a transection of half of the spinal cord. Usually it's a penetrating trauma that causes it, and the paralysis takes place on the same side as the injury. So if you have an injury on the left side of the spinal cord, you will have left arm and left leg weakness or paralysis. And then there's Cauda-Equina syndrome, which basically will give you a sciatica type syndrome plus neuro findings. So sciatica, low back pain radiating to the leg, but also you have lower extremity motor and sensory loss. You have bowel and bladder dysfunction like urinary incontinence or urinary retention, and subtle anesthesia, which is numbness between the legs. So sciatica by itself is not so worrisome, but when you have these other findings, that's a medical emergency. And so this slide kind of oversimplifies a lot of these syndromes, but it basically illustrates, the basic ideas. All right, moving along. Next question is a 23-year-old female with a history of HSV or herpes complains of facial droop. Vital signs are 98.6 orally, heart rate 98, BP 120/80, respirations 18, oxygen 100% on room air. Patient is ANO times 3, GCS of 15. Exam is remarkable for a left-sided facial droop of the entire face, including the forehead, and inability to close the left eye. No eye or tongue deviation or extremity weakness. Exam is otherwise unremarkable. Patient has no other complaints. Point of care glucose is 120. What pathology is most likely here? Todd's paralysis, Bell's palsy, Wernicke's encephalopathy, stroke, or intracranial hemorrhage. So two new terms here, Bell's palsy and Wernicke's encephalopathy. In this case, we're going to talk about Bell's palsy. So Bell's palsy is caused by essentially an isolated inflammation of cranial nerve 7, the facial nerve. And if you remember, that's responsible for facial movement, which accounts for the patient's facial weakness. It can be distinguished from stroke by a lack of other findings like extremity weakness or other neurological involvement. Also in Bell's palsy, weakness involves the entire half of the face, including the forehead. In stroke, there is weakness of the lower face only, with forehead strength intact or forehead sparing. And this is because of isolated local facial nerve involvement, not a lesion involving the cortex of the brain or the brain proper. So the mechanism for this is kind of complex, but I'll try and simplify it for the purposes of this talk. Basically, one side of the facial nerve receives input from both sides of the brain. So when one side of the brain is affected, the forehead still receives input from the other side of the brain and should not become weak. Thus, the forehead is spared. In Bell's palsy, the other side of the brain cannot compensate because the defect is in the nerve itself. So the defect takes place below the level of the brain. And next question, a 56-year-old male with a history of chronic daily alcohol abuse presents with confusion and difficulty walking. Vital signs are essentially unremarkable. On exam, you notice he's ANO times 1 to self only. That should say GCS of 14. You give him 1 off for confusion. You notice a wide-based gait, strange behavior, a nystagmus, which is eye flickering when looking from side to side, is abnormal eye movement. No eye or tongue deviation or extremity weakness. Exam is otherwise remarkable. Point of care glucose is 120. What pathology is most likely? And here, the answer C is already marked off for you. This is Wernicke's encephalopathy. So the previous patient had Wernicke's encephalopathy. Wernicke's encephalopathy is seen in chronic alcoholics and is due to a depletion of thiamine or vitamin B1 as a result of that chronic alcohol abuse. and can present similarly to alcohol intoxication and may look like a posterior circulation stroke, for example. It consists of gait instability or ataxia, confusion, abnormal eye movements like nystagmus. Also, if you notice that the patient seems to be making things up, telling stories and telling you things that they seem to be making up off the top of their head or confabulating, that's known as Korsakoff syndrome. Okay, so that about does it for the stroke mimics. Now we're going to get into stroke syndrome review to assess what we've learned today. 59-year-old male with a history of hypertension presents with right facial droop and right upper extremity weakness and speech difficulty. You suspect stroke. What is the likely pathology? Does he have a middle cerebral artery stroke, anterior cerebral artery stroke, or posterior cerebral artery stroke? So if you remember from our discussion, he's got weakness involving the right facial droop, right upper extremity, and speech difficulty. So that is the description of a middle cerebral artery stroke. And just as a reminder, the middle cerebral artery distribution of the motor homunculus is here. You see that on the right side of your screen. You can see that the upper extremity and face are included. And then you also see that Broca's area here is highlighted in gray on the left-hand side of your screen. And that is going to explain his language symptoms. Next question. A 59-year-old male with a history of hypertension, similar patient, presents with right lower extremity weakness. You suspect stroke. What is the likely pathology? So in this case, it's anterior cerebral artery stroke. And as you can see here, the anterior cerebral artery distribution is more associated with lower extremity motor weakness based on the motor homunculus. Next question. A 59-year-old male with a history of hypertension presents with dizziness, vomiting, abnormal eye movements, difficulty swallowing, hoarseness, eyelid droop. He's got a small pupil on the left, lack of sweat on the left face. He's got an unsteady gait. He has abnormal coordination. You suspect stroke. What is the likely pathology? So in this case, his symptoms are pretty classic for posterior cerebral artery stroke. So just to recap, the posterior circulation, which are branches of the posterior cerebral artery, affect the cerebellum and the cranial nerves. You can see that highlighted in red in both areas, both figures there. And that basically explains the patient's symptoms. So now that we're done with our assessment and tutorial, let's go over some pearls. So when assessing these patients, it's important to ask, when were they last seen normal? Ask the patient. If they can tell you, ask the family or witnesses or coworkers, and then ask again, because sometimes the story can change. Was it a wake-up stroke? Did they wake up with these symptoms? What time did they go to bed? What is their baseline? Have they had previous strokes in the past with residual deficits, or are all these symptoms new? What was the progression of symptoms? Did everything happen all at once, or did it come on gradually over time? Also, get your point of care glucose testing before paging the stroke alert to consider hypoglycemia. Ask about drugs, ingestions, medications. Is their altered mental status the same, or is it changing over time? Do they have a headache? Do they have chest pain? Remember that low-grade fever may be present with stroke, but may also be indicative of an underlying infectious process that's getting ready to declare itself. And remember that patients may present as seemingly only confused or aphasic with difficulty speaking. Also, remember that seizures can result from stroke, but also seizures can cause a stroke-like syndrome. that's known as Todd's paralysis. And remember that in patients with elevated intracranial pressure from a hemorrhage or an expanding stroke with cerebral edema or swelling and impending herniation, that can look like cardiac strain on EKG, which is also, again, provided to you here in the right lower corner as an example. Not to say they can't also be having a cardiac event. And then what's important to remember in patients that, either they're head injury patients, stroke patients, or patients that you're concerned about elevated intracranial pressure, always remember to avoid hypotension and hypoxemia in those patients. So again, remember to get your POCT glucose before paging a stroke alert. Listen to your patient, pay attention to symptoms, signs, and vitals. Use your LAM score. It's basically a shortened pre-hospital version of the NIH Stroke Scale, which can help assess severity of stroke. It's been found to be accurate and useful. And these symptoms may be dynamic, changing over time. So having an idea of what they were like when you first assessed them will help us guide hospital care. So, in conclusion, we learned that stroke can have many forms and many mimics, and may be difficult to discern in the pre-hospital setting, but our history of physical exam and vitals can help us out. If they meet stroke criteria, page out a stroke alert, get them to the ED quickly for definitive diagnosis and treatment. They may end up having a different diagnosis, but it may be equally or even more life-threatening. Hopefully, learning some of the underlying anatomy and pearls and pitfalls will help you the next time you assess a patient suspected of having a stroke. And lastly, keep in mind what you do matters. Your pre-hospital assessment and care that you provide for our patients and the information you convey to us on arrival to the ED and transition of care is crucial to the care that they receive in an emergency department and once they're admitted to the hospital. Thanks for listening. Stay safe out there.